I'll be presenting a case report titled Silent Occlusion Myocardial Infarction Precipitated by Exercise Stress Testing. I'm Brian Lestars. I'm a second-year fellow at Henry Ford Hospital in Detroit, Michigan, and Dr. Modi is my mentor for this case. We have no relevant financial relationships to disclose. As an introduction, exercise stress testing is frequently employed for cardiac risk stratification prior to elective surgery. Although generally safe, the incidence of MI or death from exercise testing is reported to be anywhere around as high as 0.04%. We present a case of exercise stress testing precipitating a silent occlusion MI that evaded detection during the stress test itself. Mr. O is a 59-year-old male with a history of hypertension, hyperlipidemia, diabetes, prior tobacco use, and severe cervical stenosis, who was planned for cardiac stress testing prior to elective laminectomy. 5 days prior to his stress echo, he experienced new severe intermittent epigastric pain, unlike any he'd ever experienced before, with associated shortness of breath, nausea, and vomiting, diaphoresis, as well as some diarrhea. He attributed his symptoms to an episode of presumed gastroenteritis for which he did not seek medical care. These symptoms gradually subsided over the next 48 hours, after which he noted new persistent fatigue. 4 days after the resolution of his epigastric pain, he presented to an outside location for his exercise stress echo. He achieved 5.7 METs before terminating the testing due to fatigue. During the test, he endorsed no symptoms of ischemia, and the accompanying stress ECG that was read by a staff cardiologist was read as negative for ischemia. We'll take a closer look at a couple of these EKGs here in a minute. There was no hypotensive response to exercise, ventricular arrhythmias, or other high-risk features. The stress echo findings were reported as echocardiographic imaging is grossly normal post-stress. However, the study is limited as not all left ventricular wall segments are clearly visualized. So here's his resting EKG. I want to particularly draw your attention to the inferior leads, as they'll be most notable for ischemic changes later. On baseline here, there's some borderline questionable ST elevation isolated to lead V3, and mild submillimeter ST depressions and one in AVL, horizontal and one downward sloping in AVL. Again, these are in the absence of any ongoing symptoms other than this new fatigue he's been having for the past few days. This is his EKG at the end of the testing, at the end of the recovery period. This marks the end of the monitoring that he has at this other private practice cardiology non-invasive testing center. And here we see he's still recovering from tachycardia. He did have some atrial arrhythmias at the end of his stress portion that are sort of resolving here. Additionally, we see no substantial ischemic changes in the inferior leads, some very minor upsloping depressions perhaps in lead 2, some mild ST depressions again seen in 1 in AVL, similar maybe slightly worsened elevation in V3, but otherwise, again, read as negative throughout the test for acute ischemic changes. So luckily for him, he came directly from this stress test at another location to our hospital for a pre-op EKG that had also been ordered ahead of the surgery. And during this EKG, we found some significant changes compared to the EKG that we just left off at the end of his stress testing. This was what was found, again, with no symptoms of ischemia at the time that this EKG was acquired. But now we have new inferior Q waves in all the inferior leads, as well as a millimeter ST elevation in 3 and sub-millimeter ST elevations in 2 in AVF as well. Now with those ST depressions, 1 AVL looking a lot like reciprocal depressions for a possible evolving STEMI. Perhaps even some subtle sub-millimeter depressions in V2 and V3 as well. Given these findings, we performed a stat bedside echo, and I unfortunately don't have a video to show you here, but there was preserved EF, but some subtle basal to mid inferior wall hypokinesis and pretty easily recognizable RV free wall hypokinesis, concerning for potential RCA STEMI. As far as this patient is concerned, he was asymptomatic and he just finished the stress test within the past hour, and he was under the impression that he had passed and he didn't have any diagnosis of CAD. Given this evolving dynamic EKG changes and our echo findings, we took him emergently to the cath lab, and angiography demonstrated a 100% acute thrombotic occlusion seen here with the proximal RCA. The PCI of this lesion was notable for extensive thrombus burden and diffuse disease throughout his RCA. He ultimately had PCI from the proximal all the way to his distal RCA. Troponin collected at the time of his ischemic EKG before taken to the cath lab was 8,881. High sensitivity assay at our hospital, and a repeat after successful PCI was 13,200, showing an upwards trajectory of that troponin. Repeat echo done the next day showed persistent RCA territory hypokinesis with a preserved EF of 50-55%. So for our discussion, MI is a known, albeit rare, complication of exercise stress testing, with one retrospective review of 5,060 CPET studies documenting one singular instance of STEMI, resulting in an estimated incidence of about 0.02%. Additionally, MI in the past 48 hours, we all know, is listed as an absolute contraindication of stress testing by the AHA. This patient may have had an ischemic event 4 days prior to stress testing that heralded an underlying vulnerable plaque in his RCA. His symptom constellation is certainly concerning for ischemia, although the diarrhea is not explained by a possible ischemic event. But the new severe stuttering, epigastric pain with associated shortness of breath, nausea, vomiting, diaphoresis are all concerning. The absence of Q waves known as pre and post stress ECGs, followed by new inferior Q waves and ST elevations, show dynamic evolving process of not only a STEMI, but scarily in this case a silent STEMI that was likely precipitated by the exercise stress test, but not detected during the stress test itself. One can speculate a more perilous outcome had he gone home after the stress test. This case illustrates the potential for delayed ischemia beyond the initial monitored recovery period of exercise stress testing. In conclusion, exercise stress testing is generally very well tolerated and safe. However, occlusion MI remains a rare but real risk. MI precipitated by exercise stress testing may manifest shortly following the completion of exercise testing rather than during the test itself. And as such, a prolonged recovery monitoring period may be beneficial with those who endorse recent symptoms suggestive of ACS. Thank you for your time.